Hello guys, Dallas Holiday, OGME4 here. So today we're going to be talking about pulmonary ultrasound to go along with our pulmonary curriculum for the month. The objectives for this lecture are to do pulmonary ultrasounds on your patients. I know it is challenging that all of our sites have different ultrasounds that are often in various states of operation or not operation, as the case may be. But the benefit of that is that if you use the ultrasounds when you're done with residency, you will be capable of walking into any ER across the country, picking up the ultrasound and being familiar with it and have seen enough examples of ultrasounds to know how to operate it. So I really encourage you to get the probes out, put them on your patients, because if you don't do it now, this isn't something you're going to pick up and learn after your residency. So this is the time to do it. And ultrasound is only becoming more prevalent. It's not going away. So do yourself a favor, get the machines out, make it a point on your slow days to start ultrasounding some patients so you can get good at this. And that's it. I'm done. I'm off my soapbox, but please do it. So first thing we're going to discuss is pneumothorax. I think that this is probably where most of us are familiar with lung ultrasounds when it comes to adding this on to our FAST exams. And if you weren't familiar with this prior to today, well, get ready because you are about to learn. So when we do our exam for the pneumothorax, we're going to be using the linear high frequency probe or the curvilinear probe. The linear is going to be preferred. And you'll see when you actually do this with your patients that the linear is much easier to work with and it's much easier to see. So essentially you're going to align the probe sagittally in the mid-axillary line with the probe indicator oriented towards the patient's head. With all these exams, the probe indicator is always going to be oriented towards the head. That's just the standard. And that's kind of what they're trying to indicate there on that image with that little green dot. They're showing you that that's where the probe indicator is. So essentially, you're going to scan down the entire anterior chest until you get to the diaphragm to check out the entire lung for pneumothorax. This is slightly limited in the sense that you only get a view of the anterior chest. So if you manage to have a posterior loculated pneumothorax, you're not going to find that. But again, I'm not even sure you'd find that on chest X-ray, to be quite honest. So during this exam, you're going to visualize the pleura as this echogenic line between your rib shadow. You're just going to watch as the patient inhales and exhales for pleural sliding. If you don't have pleural sliding, then you have a pneumothorax and you have a problem. So here essentially is what you're going to see putting the probe on. You're going to see your ribs, which are going to block ultrasound. You're going to see your intercostal muscles, and then you're going to see your lung. And between the intercostal muscles and the lung is going to be that bright line right there. That's your pleural line. And that's where you're going to see this movement in an actual movie clip. So here's an image of no pneumothorax. You can sort of see that line sliding along there. And when you look at this in the literature, it's described as shimmering or ants on a log. And here's an image of pneumothorax. So there's still movement because, there's still going to be movement in the chest, but that line isn't sliding. And again, you can see your rib shadowing there, particularly on the left. Now, I promise if you can't quite make this out now, when we get to the hands-on session, it's going to be much more clear, although we probably won't find a pneumothorax, but So let's say you think maybe there's a pneumothorax there, but you're not 100% sure. You can go ahead and put your machine on M mode. If you look at any machine in any of our departments close enough, you're going to see a button that says M mode. Press that button, and boom, you will be in M mode. Pleural motion in M mode is detected as a seashore pattern, which I'm going to show you an example of. So here you've got your machine on M mode. You've got your subcutaneous tissues on the superior aspect of this image, which are not moving. Those are static. You have your pleural line. You can see that arrow indicating there. And then you have this wavy pattern that's generated by the lung sliding motion. And this is what we call the seashore sign. So normal sliding, seashore sign. Pneumothorax results in what's called the barcode or the stratosphere sign. And this is going to be abnormal. It's going to be very apparent. So here's normal, and here's not normal. So you can see on the image on the left there, that little tiny string at the top is showing you where your probe indicator is and where you're actually getting your M mode from. So you can see in that little image that you've got your rib shadowing, you've got your lung, and then you go down to your M mode screen, you can see again, subcutaneous tissues not moving. That blue arrow is pointing at the pleural line. And then you can see that seashore pattern created by the lung movement below it. And then to the right, you can see a really great example of the M mode showing you the stratosphere or barcode sign. So you can see there, instead of having that nice shimmering seashore pattern, it's just all looks like a barcode. So again, this is going to be something that's going to be hard to miss. Next, we're going to talk about pleural effusion. This is going to be pretty useful on exam for finding your pleural effusion because it's very fast. So for this exam, you want to have the patient in the seated position. They can tolerate this because, remember, fluid kind of follows gravity. So you want all your fluid to be in that dependent portion of the lungs so you can actually visualize it. Additionally, this is useful if you happen to work in a shop where you do your own bedside aspirations to locate a nice pocket and do ultrasound guided aspiration if you're doing that therapeutically or you're going to be sending a sample for culture or whatever. Super useful for that. As with our other exams, you can use the curvilinear or phased array cardiac probe. That's the little square probe. I think this is preferable for this exam because the biggest obstacle to this exam and looking for pulmonary edema is going to be getting through the ribs. And that cardiac probe has a smaller footprint, so it's going to be easier to maneuver than the curvilinear probe. But if the curvilinear probe is all you have, it'll work. So you're going to be looking basically just above where you're doing a fast exam for your Morrison's pouch and your spleen. So you can locate the Morrison's pouch on the right and then just scan up a bit and locate the diaphragm, which will be just above the liver, and you're going to look at the lung. So you should see no black space. Now, if you see fluid that's going to appear as a hypoechoic, i.e. dark region, is going to be present on inspiration and expiration. That is going to be consistent with a pleural effusion. With the ultrasound, you actually may detect as little as 20 mLs of fluid. Chest x-ray may require up to 150 mLs, and it may miss pleural effusions if the patient is supine because they're going to layer out and they won't be as apparent. So here's an image of no effusions. You can see there you've got your liver, you've got your kidney below it, you have that nice echogenic line representing the diaphragm, and you don't see any dark fluid above it. It almost looks like there's liver above it, which is not something I get into, but it's artifact. I'm not going to get into the physics of that, but that's normal. So here you can see on this image, again, you've got your liver, you've got that nice echogenic line above it, and then you've got all that dark space that's present on inspiration and expiration. That is pleural effusion. That is fluid. Next, we're going to discuss pulmonary edema. Again, curvilinear or phased array, but for the same reasons I've already mentioned, I think the phased array or the cardiac probe is better. The patient can be really in any position, so whatever is comfortable for them, just let them do that. When you're doing the scan, the chest is divided into 4 zones on each side, and you're going to scan each zone for edema. And with all our other exams, the probe marker is going to be pointing towards the patient's head. So here are your 4 zones. You've got 2 that are going to be medial to the anterior axillary line, and then 2 that are posterior to the axillary line. And you're going to do this bilaterally in your patients. So what are you going to see when you put the probe on? Well, number one, you're going to see a lot of rib, so you're going to have to fight that, which again is why I think the cardiac probe is more efficient. But if you see these A lines, they're horizontal, regularly spaced, echogenic lines that represent normal artifact. This is likely what we'll see when we're actually in the hands-on lab. This is okay. You should see this, or you can see it, in like COPD or asthma, things like that. Asthma. Now, if you see B lines, these are going to be vertical lines below the pulmonary interface. They're basically going to extend from the pleura all the way to the edge of the ultrasound. Now, if they don't extend all the way to the edge of the ultrasound, they don't count. These are called comet tails. They're not B lines. B lines are essentially equivocal to curly B lines on chest x-ray. The B lines must move with respiration, and again, must extend completely to the end of the screen. So you can see here on the left, that's normal. So there you have those horizontal echogenic lines representing normal artifact. Those are A lines. And then on the right, you can see there you have that echogenic line at the top. That's your pleura. And then you've got these vertical lines that are extending all the way down towards the edge of the image. Those are B lines. Remember, B lines only suggest an increase in fluid, which may be found in a variety of pathologies such as bilateral pneumonia, ARDS, bilateral contusion. However, I think this exam is really useful in those mixed COPD and CHF patients when the etiology of their dyspnea is not immediately clear on history and physical. So potentially maybe they're not wheezing that much, or they're not giving you a lot of history about orthopnea, PND, ankle swelling, or weight gain. So you can throw the probe on, and that can give you potentially an idea of what direction you need to head with treatment, or if there's something else at play. So pulmonary edema is present when you have 3 or more B lines in 2 or more regions on one side of the chest. So if you have both sides of the chest, then you have bilateral pulmonary edema. If you only have one side, then you have unilateral pulmonary edema. So here's an actual moving image of the A lines. Again, this is what we're going to see when we actually get into the lab. And this is normal. Here, you've got these B lines. Again, you've got that echogenic line at the top. That's your pleura. And then you've got these vertical lines extending all the way down to the edge of the image, and they're moving with respiration. These are B lines, and this is consistent with edema. That's it. Here are my references. Again, if you want to view any longer videos that actually go into a little bit more in detail, you can look at 5 Minute Sono. Big thanks to those guys for sending me a bunch of material. They were super helpful. Everyone in the open access education community has been really awesome this last month, responding to me, my questions, and my emails. So that's been awesome. And if you guys have any questions, do not hesitate to contact me. Riley will be with you next week doing the actual lab. And I will be out for August and September as I'm off service, but I will see you all back in October. Again, remember, ultrasound your patients.